Good afternoon. I'm delighted to be here, and I want to thank the HRB-TMRN for the invitation to speak today. And what I wanted to discuss today was actually a real-world example of where we've endeavoured to embed a clinical trial into the Irish healthcare system. And you can judge how pragmatic our trial was and how well we managed to embed it within the clinical practice within a busy ICU in a number of different countries. So before I start, there's just some disclosures I'd just like to mention. I've received funding from the HRB and other funding organisations to support the work I'm going to talk about today. And I've previously done some consultancy work on pandemic preparedness for the University of Oxford on a Horizon 2020 project. But really, I suppose the major disclosure today is actually that the work I'm going to talk about today is a collaborative research project that has been undertaken by a huge number of people in many different intensive care units in many different countries. And this is work that has actually gone over a number of years. And particularly, I have to acknowledge Paul Young, the lead investigator on this pretty innovative project, for all of his work. So this is where my day job is. This is the intensive care unit, or the ICU. And we look after critically ill patients who require organ support. And while it's a busy, sometimes chaotic, high-pressured environment, it is really important that we do research in this area to determine what treatments can reduce mortality, death, and reduce organ failure and long-term disability in our patients. And despite this being a challenging environment to conduct such research, if we can successfully deliver trials in this environment, it's key that we have them embedded in the clinical pathways and to make the trials as pragmatic as possible, not only to increase generalizability, but to actually increase the acceptability of trials in this environment. So the trial I was going to talk about today is the Peptic Trial. And this is a trial of proton pump inhibitors versus histamine 2 receptor blockers for ulcer prophylaxis in intensive care unit patients. This was published in JAMA in January 2020. This was before COVID, when the world was normal, so it seems like an age ago now. And well, first of all, what is stress ulcer prophylaxis? So this is the administration of drugs by ICU doctors to reduce acid erosion of the stomach in critically ill patients. And this can result in upper GI gastrointestinal bleeding, and actually has resulted in death before as well. Now, while this trial is, the topic's interesting, the results are interesting, the real key in this trial is actually the methodology that we have employed and how this might actually have implications for future research studies in ICU and well beyond. So this was a study that enrolled over 26,000 patients, making it the largest ICU study completed to date in over 50 ICUs in 5 countries, and it managed to do all of this on a budget of under $500,000 US. So I'm going to talk a little bit more about how we did this, but before I do, I'm going to start with some of the background about the clinical problem, so for the non-intensivists, you can understand what we're talking about. So stress ulcer prophylaxis is prescribed very commonly in the ICU. In fact, the vast majority of mechanically ventilated patients in ICUs in the developed countries receive it. The most commonly administered medicines are either PPIs, which are proton pump inhibitors, but a sizable number of patients also receive H2 receptor blockers, or histamine 2 receptor blockers, H2RBs. Indeed, in some ICUs, H2RBs are used more commonly, but the variation in practice has more to do with doctors and hospitals than it does with patients. So people choose PPIs because they appear to be effective at reducing the risk of GI bleeding in ICU patients with risk factors. One potential reason to choose H2 receptor blockers instead of PPIs is that the profound acid suppression from PPIs might result in bacterial overgrowth in the stomach, and then critically ill patients might reflux the bacteria and get a pneumonia. In addition, PPIs have a number of immunosuppressive effects. The clinical significance of these effects is unknown, but for critically ill patients, they might matter. One concern is that the combination of these effects might result in increased risk of developing C. diff infection with PPIs instead of H2RBs. And C. diff infections, it can be a serious complication in critically ill patients. The comparative effect of using PPIs or H2 receptor blockers for stress ulcer prophylaxis on mortality is unknown because adequately powered RCTs comparing these medicines have not been undertaken. This is despite the fact that we've been giving these medicines to critically ill patients for more than 20 years. One would anticipate that any effect on mortality is small. Small effects on mortality are plausible, and for ubiquitous ICU therapy like stress ulcer prophylaxis would be profoundly important on a global scale. Approximately 2.5 million patients are ventilated in the ICU per year in the developed world alone, and 90% of these are given stress ulcer prophylaxis. A 1 percentage point mortality difference between these patients would amount to 25,000 lives being saved or lost each year by making the incorrect choice. So we conducted a multi-center, cluster randomized, crossover registry trial comparing the safety and efficacy of proton pump inhibitors with histamine 2 receptor blockers for ulcer prophylaxis in intensive care patients requiring invasive mechanical ventilation. The cluster crossover design means that we randomized ICUs instead of patients. Because of the crossover, each ICU provided patients for each treatment group, both PPIs and H2RBs. Because variations in outcomes occur over time, both within each treatment period and between each treatment period, this design provides less power than an individual patient randomized trial. We use data from existing sources to estimate these temporal trends. We did this in order to conduct power calculations and estimated that we would have an 80% power to detect a 2.4% absolute difference in in-hospital mortality between groups. With a baseline mortality rate of 18%, we ultimately had 80% power to detect an absolute mortality difference of 1.8% and a 90% power to detect a difference of 2.2%. In the event of no observed difference, we would expect our effect size estimates to be sufficiently narrow to exclude the possibility of an increase or decrease of mortality for around 1 percentage point. Arguably, for the first time in an RCT in the critically ill, we'll have sufficient power to detect what might reasonably be considered as a minimally clinically important difference. So because this was a cluster randomized trial, instead of randomizing individual patients, we randomized ICUs. In 50 ICUs in hospitals from 5 countries, we compared 2 approaches to stress ulcer prophylaxis in adults who were mechanically ventilated. One approach was to use PPIs as the default treatment when stress ulcer prophylaxis was prescribed, and the other was to use H2RBs. With the order of treatments randomly allocated, each ICU used one approach to stress ulcer prophylaxis for 6 months and then switched to the alternate approach for the subsequent 6 months. To reduce costs, we used existing data sources wherever possible. So demographic data, illness severity data, ICU and hospital length of stay, duration of mechanical ventilation, and mortality data came from existing registry data sources. Every patient who was mechanically ventilated within 24 hours of ICU admission was included in the study, except for those patients who were admitted to the ICU with an admission diagnosis of upper GI bleeding. These patients get proton pump inhibitors as default, as a standard rescue therapy, and were excluded. 50 ICUs were invited to participate. 50 ICUs randomized patients. 25 used PPIs first. 25 used H2 receptor blockers first. We can see that some patients were excluded because they actually were admitted to the ICU with a diagnosis of upper GI bleeding. And also, some additional patients were excluded because they were readmitted to the ICU. We only randomized patients on their first admission to ICU. In addition, some additional patients in each group were excluded because either they opted out of study participation or a small number of patients had mortality data missing. But over 98.9% of patients in each group were included in the primary outcome analysis. So when we looked at our baseline comparisons, the groups were actually very evenly balanced, with the age being approximately in the late 50s. The majority were male, 50% were medical patients, 50% were surgical patients, a third were elective surgery, and an Apache score of 19 means they were actually quite sick. As we already said, we've compared study treatment strategies that were implemented at the level of the ICU and not the level of the individual patient. Any PPI was allowed to be used, as was any H2 receptor blocker. The study treatments were administered open label. This was necessary because of the scale of the project. Clinicians decided whether or not patients would receive stress ulcer prophylaxis. That was up to the discretion of the treating clinician. However, once they chose to prescribe stress ulcer prophylaxis, the default prescription of either a PPI or a H2 receptor blocker was that allocated to that ICU in that period of time. Patients who were taking a PPI or a H2 receptor blocker prior to ICU admission were switched into the treatment strategy assigned to that ICU, and then for the duration of their stay. Patients who remained in the ICU through a crossover period continued to receive the treatment they were originally assigned. No washout occurred between crossover periods, and the duration of the study treatment was either until death, until ICU discharge, until the development of a clinically significant upper GI bleeding, when PPIs are routinely given, or until the treating clinician considered stress ulcer prophylaxis was no longer indicated. And importantly, the treating clinician could decide whether to give a PPI or a H2 receptor blocker for any particular patient if they considered that one treatment was preferable or not. And if an upper GI bleeding occurred, a PPI was administered at clinician's discretion in accordance with standard practice, irrespective of treatment allocation. We collected data on study treatments used in a variety of ways, but do not have individual level data on stress ulcer prophylaxis for the whole study sample. However, we do have it for a subgroup. So among those who received PPIs, an estimated 82.5% received PPI, 4.1% received H2 receptor blockers, 1.9% received both, and 11.5% received neither. In the H2 receptor blocker group, 20% got a PPI, 63.6% received a H2 receptor blocker alone, 5.1% got both, and 11.2% received neither. The primary outcome for this study was in-hospital all-cause mortality during the index hospitalization up to 90 days from the date of ICU admission. In the Peptic study, we ended up with a very big sample and a very precise estimate of treatment effect. Power depends in large part on the number of events, in this case deaths. In the Peptic study, there were more than 5,000 deaths. 18.3% of the PPI group died, and 17.5% of the H2 receptor blocker group died. In relative terms, the risk ratio for death in the PPI group compared to the H2 receptor group was 1.05, with a 95% confidence interval of 1 to 1.0. The most accurate interpretation is that our findings are consistent with an effect on mortality that ranges from no effect to a 10% relative increase in mortality by using PPIs instead of H2 receptor blockers. If we make our confidence intervals wider, you can see that even with 99.9% confidence intervals, the interpretation is essentially the same. An absolute difference suggesting by point estimate that, if the absolute difference suggested by point estimate was the true difference, then this would correspond to 23,250 lives saved if H2 receptor blockers were used instead of PPIs as the default strategy. When we looked at our secondary outcomes, we found that actually there was a significant reduction in bleeding events with PPIs as opposed to H2 receptor blockers. And our data did not support the notion that PPIs increase the risk of ICU C. diff infection. So I think you can see from this study that we were able to conduct a large study that was able to enroll large numbers of patients in the ICU with very few exclusions, and was able to incorporate the interventions into the routine clinical practice, as well as actually data collection being incorporated into existing sources. So this resulted in a highly efficient trial. And as we said at the start, this is changing things going forward. So since then, there's another study, again, led by my friend Paul Young from New Zealand, called MEGAROX, which is going to be a 40,000 patient registry-based study that is actually going to randomize patients at the individual level. So it's not a cluster trial. And it will be, when completed, the largest ICU trial to date. And again, using many of the features that we used in this Peptic trial. So again, we're very happy to take any questions that anyone may have on the trial, what we tried to do, what we failed to do, and what we could do better next time. Thank you very much.